آه، بسم الله الرحمن الرحيم. برحب بحضراتكم في المراجعة بتاعة الموديول بتاع البرين. وزي ما احنا متعودين فبيكون في مجموعة من الحالات بندسكس مع بعض فيها، وفي نفس الوقت انتوا بتبعتوا الإجابة على الشات، واحنا بنتصرف بعد كده في توضيح الإجابة الصحيحة. من الحالة الأولانية, then this is the first case of a female patient 81 years old. She is hypertensive, presented by coma. Okay, and then the answer is right, and this is an intracranial hemorrhage. But there is a unique feature in this particular case where you got what's known as the sedimentation level. This can occur in the huge type of hematoma, where you got some sedimentation of the blood, and this will appear as this fluid level, as you can see. Also, the hematoma can extend, of course, inside the ventricle, and this is known as the hematocrit effect, and is well known in many places in the body, like the peritoneum. When you got an intraperitoneal hemorrhage, there may be some sedimentation level also in the peritoneal recesses. The second case is a female child, 4 years old, and this is the pre-contrast CT scan and post-contrast CT scan. The answer is not right. This is, of course, not a lymphoma. This is a tumor that is inside the occipital horn of the lateral ventricle, and in this pediatric age, and the enhancement and the border of the lesion all are diagnostic of the choroid plexus papilloma. Next case is a series of MRI, including the T1, T2, flare, diffusion, and ADC images. Okay, and the answer is that this is an acute intracerebral hematoma, is clearly seen in the CT image, but on MRI you see the intermediate signal of the lesion in the T1, the very dark signal in the T2, and the flare with some surrounding edema. In the diffusion weighted images, you got what is known as T2 black through, which is the opposite of T2 shine through, where you got the lesion is very dark in the diffusion weighted images as well as in the ADC, and this is one of the criteria of hemorrhage on diffusion weighted images. The next case is a female patient, 45 years old, presented by headache, and this is an axial and coronal MRI T1 post contrast. Okay, and this is of course an abnormal vein coming from the surface of the brain with some internal tuft of veins, which is a classic of developmental venous anomaly, which is known in the literature as leave me alone lesion. And this lesion is considered a normal variant, and it is not an arteriovenous malformation and should not be diagnosed as arteriovenous malformation, because if you surgically remove this lesion, or if you try to embolize, you will damage the normal brain and you got an infarction. This is a normal variant. This is the child, 7 months old, with psychomotor delay and ataxia. The diffusion weighted images show that there are areas of diffusion restriction in the very characteristic locations, like the midbrain, the periaqueductal area, and the basal ganglia. Of course, I am not controlling the appearance of the answer, but this is Leigh's disease, and the MR spectroscopy showed the prominent feature of the high lactate peak, which will be inverted in the long TE sequences. And you know that Leigh's disease is a mitochondrial disorder with neurodegeneration that may lead to death, usually in the childhood. This is the incidence, and the typical symptoms appear at the age of 2 years by psychomotor delay or regression, basal ganglia or brainstem dysfunction, resulting in ataxia, ophthalmoplegia, and dystonia. The MRI will show changes in the basal ganglia as well as in the periaqueductal gray matter. Then this is almost a classic appearance of Leigh's disease. The next case is a patient with headache, fever, neck stiffness, and seizures. Also with personality changes. Okay. Yes, and this is, as you can see, this is a case of herpes encephalitis, and the answer is right, where you got bilateral, almost symmetrical lesions in the temporal lobes around the sylvian fissures, and these lesions are bright in the T2 and the FLAIR images with some diffusion restriction. The diffusion weighted images may also show some other lesions in the frontal and maybe the parietal areas. Then this is an MRI of a female patient, 35 years old, and this MRI includes the T1, T2, FLAIR, and the diffusion weighted images. Okay, and this is of course the neoplasm. As you can see, there are two big masses in the region of the thalami that are more sizable on the left side with no diffusion restriction, and this is known as diffuse thalamic glioma, or diffuse midline glioma, which can involve also the brainstem. The next case is a patient with headache, confusion, seizure, nausea and vomiting, speech and memory problems. The MRI of the patient includes the T1, FLAIR, T2, axial and coronal post-contrast images. Okay, the answer is subependymoma, and this is a tumor that occurs inside the ventricle. Characteristically, it does not enhance in about 60% of the cases, and this is the only way to spot this lesion. The absence of contrast enhancement, as you can see here, is one of the diagnostic criteria of subependymoma. But in about 40% of the cases, ependymoma can enhance, subependymoma can enhance. At that time, you cannot reach the diagnosis, and you may think of another alternative like the ependymoma itself. The next case is a 72 years old male. He is alcoholic, presented by altered consciousness and diagnosed by hyponatremia and was put on sodium corrective measures. Okay, and I don't know why these answers can appear before I click, but no, this is not vernix encephalopathy, because vernix encephalopathy is the characteristic appearance in the area para midline in the around the third ventricle, and the history here is very pathognomonic, where he got hyponatremia and corrective measures. Then this is the pontine myelinolysis, where you got an abnormality in the bones, and this abnormality is exactly similar to the Mexican cap in the MRI. And if the changes occur in the basal ganglia as well, as you can see in this particular case, then this is known as pontine and the extrapontine myelinolysis. The lesions will not show diffusion restriction if they are chronic. But if the condition is acute, then you may got diffusion restriction in the pontine lesion as well as in the extrapontine lesions. Then this is a female patient, 76 years old, presented with no significant clinical background apart from amnesia. Okay, in this flare and the T2 weighted images, and you can see many cystic lesions, particularly in the basal ganglia. And these lesions are exactly of CSF signal in the FLAIR and T2 weighted images. And this is diagnostic of Virchow-Robbins spaces. In these Virchow-Robbins spaces, here they are more prominent and more numerous, but this is expected in some of the patients, and this should not be misdiagnosed as infarctions or as MS Blix, for example, if the patient is young. But the location of the lesions in the brainstem, in the basal ganglia, in the high parietal areas, and the appearance of the lesions having CSF signal in all blood sequences are diagnostic of dilated Virchow-Robbins spaces. And here you got a female patient, 30 years old, with severe headache and seizures. This is the CT scan of the brain and the MR venogram, and there are some choices. Yes, number B. Yes, the answer is right, and this is a left temporal hemorrhagic infarction, venous infarction. And the MR venogram showed absence of flow in the transverse sigmoid and the sigmoid sinuses on the left side, and this is the consequences of venous thrombosis in the form of hemorrhagic infarction ipsilateral to the venous abnormality. And here you got a lesion, big lesion in the frontal area on the left side. This is T1 and this is T2 and this is T1 post contrast, and there are choices. Yes, and this is of course a glioblastoma multiforme. In the T1 weighted image, you got high signal denoting the presence of internal bleeding, which is one of the criteria of malignant tumors, the bleeding as well as the necrotic tissue. This patient is 50 years old with extensive changes in the white matter. Leukodystrophy is a disease of the pediatric age group, but in all patients, you think of an ischemic changes in the white matter like subcortical. No, this is of course not metachromatic. The patient is very old for this diagnosis, but you think of ischemic changes. And the disease here is the subcortical arteriosclerotic encephalopathy, but it is not usually seen in this particular relatively younger age. And also you got the prominent feature of involvement of the temporal lobes, which is suggestive of this particular autoimmune disease known as CADASIL. And this CADASIL is an autosomal dominant vascular disorder, and this presents by multiple or extensive white matter infarctions in a relatively younger age compared to the age of subcortical arteriosclerotic encephalopathy, and the affection of the temporal lobes is very prominent in this disease, where you got ischemic changes in the white matter and also ischemic changes in the temporal lobe. And the regular subcortical arteriosclerotic encephalopathy affection of the temporal lobes is extremely rare, while in CADASIL, affection of the temporal lobes is one of the essential findings for the diagnosis of the disease. This patient is 63 years old, and she is hypertensive with chronic obstructive pulmonary airway disease. She is also obese, diabetic, and she has hyperlipidemia presented by altered mental status. Okay, and In general, if you, these are of course diffusion weighted images, and you got areas of diffusion restriction in a very characteristic location on either side of the third ventricle. Yes, the answer is right. The artery Percheron. This is right. Restricted diffusion is seen in acute infarctions and also in inflammatory conditions. And the characteristic location of the lesions on either side of the third ventricle is diagnostic of artery of Percheron infarctions. This artery is an anatomic variant arising from the posterior cerebral artery, and it usually supplies the thalamic region and also may be part of the midbrain. Then, if this artery is occluded for many reasons, then you got these two infarcted areas on either side of the third ventricle in the region of the thalamus. The incidence of artery of Percheron stroke is about 2%. It is seen, of course, in the clinical practice, and it affects the vertical gaze of the patient and may simulate other disorders like Wernicke's encephalopathy and metabolic encephalopathy. Hyperlipidemia and hypertension are, of course, risk factors for occlusion of this artery. CT may show normal finding, but MRI will show bilateral medial thalamic infarctions in a characteristic appearance of occlusion of the artery of Percheron. And this is also the appearance. And the T2 weighted images, you got two lesions in the thalamus, bright signal in the T2, bright signal in the FRAIR, and the restricted diffusion in diffusion weighted images. This patient is 48 years old, presented by progressive weakness and sensitivity loss in her right hand. The MRI is an axial T2, coronal flare, axial T1 post contrast, and the diffusion weighted image. This lesion is now, I don't know why, frequently seen in the clinical practice, but it is usually or sometimes misdiagnosed. Then I wanted you to see it. This is, of course, demyelination, but a specific type of demyelination, which is known as the Bellus concentric sclerosis, which is one of the variant of MS. And this lesion may be single or multiple, and you got layers or concentric layers within the lesion, and hence its name. When the lesion is surrounded by perifocal brain edema, and if you inject contrast material, then the margin of the lesion will enhance, and this margin will also show diffusion restriction in the diffusion weighted images. So because it is now seen frequently, I don't know why, I wanted you to know something about this lesion so you can be able to diagnose if you are confronted by similar case. This is a CT scan obtained at day 1, day 10, and day 35 of a patient with this lesion. Yes, and this is the site and the appearance of an epidural hematoma, which is showing some aging process. The hematoma was bright in the CT scan obtained in the first day, then the density decreased by the day 10 and is now chronic epidural hematoma. This is not usually the case for epidural hematomas to pass the way from acute to chronic, because epidural hematoma is present in a tight space, and it produces significant symptoms. Then it is evacuated before being passed into the chronic phase. The next case is a young adult with headache, and you got a lesion in the frontal lobe in the T1 and in the T2 weighted image. This lesion is classic for cavernoma. The answer is right. And you see the hemosiderin rim around the lesion with the popcorn appearance and the absence of perifocal brain edema, the absence of mass effect. This is the classic appearance for cavernoma. This patient had an MR, MR angiography, and the axial flow sensitive technique, the gradient image. Yes, the answer is right. This is Moya disease, and you can appreciate the answer from this angiogram. You see the vertebral arteries and the basilar artery, and you see some of the carotid course, but you cannot see the major intracerebral branches. And also here, instead, you got too many collaterals in the basal cisterns, which is a diagnostic finding for the Moya disease. Next case is a male patient, 30 years old, presented by seizures. And this is the MRI T2 flare and T1 post contrast. And this is the MR spectroscopy. Um, Actually, we cannot say that this is low grade, but it's that this is diffuse astrocytoma. The diffuse type does not enhance, and it will show the curve, the spectroscopic curve of a tumor in the form of depression of the NAA peak and the elevation of the choline peak, and also you got high lactate peak. This is an astrocytoma diffuse type. This patient is 54 years old. He is known to have renal cancer and presented by headache. And this is axial T1, T2, flare, contrast, axial, and corona. So of course you have the right to diagnose this as metastasis because you know that the patient had a primary malignancy. But you should know that even in the presence of a known primary malignancy, the patient may have other lesions that are benign. Then the choroid plexus papilloma is the lesion of the pediatric age group, is not a lesion of an adult. In spite of that, this is a classic site for the choroid plexus papilloma, and also the border can fit with choroid plexus papilloma. The internal vascularity also can fit, but the age is not suitable for choroid plexus. Then you think of a meningioma. Then you may diagnose that this is a metastatic deposit to the choroid plexus, and you may think that this is an intraventricular meningioma with metastasis inside. This can be seen in the clinical practice, but usually in the presence of a primary malignancy, we try to relate the findings to the primary lesion. But sometimes this will not fit, since many of the patients with primary malignancy may have other benign conditions, and this lesion has proved to be an intraventricular meningioma. This is a male, 72 years old, with headache and abnormal behavior. Yes, and of course, this is the lesion that is crossing the midline from left to right or centered in both frontal lobes is known as butterfly lesion. And the butterfly space occupying lesion can fit for many of the diagnoses, like butterfly glioblastoma multiforme, lymphoma, metastasis, meningioma, sometimes, and giant tuberculoma is included in the differential diagnosis. But on top of the lesions, of course, whenever you are confronted by a lesion which is heterogeneously enhanced, you think of butterfly glioma. Whenever you are asked about the differential diagnosis, you say lymphoma, then metastasis. This is a male patient, 30 years old, went into coma after exposure to heating gas in a closed environment. Of course, this history is extremely important to reach the diagnosis. And many times we do not have the appropriate history to help us to reach the diagnosis. And in this particular case, and in this particular history, the diagnosis will be carbon monoxide poisoning. And the carbon monoxide poisoning is one of the lesions, one of the conditions that can cause lesions in the basal ganglia, especially in the globus pallidus areas. And the frequency of basal ganglia lesions has pushed me to make some of the let's say short notice about these particular conditions. Carbon monoxide poisoning is diagnosed by history, and there may be headache, dizziness, conscious state abnormal, seizures. Then in chronic conditions, you got abnormal gait and incontinence. Carboxy hemoglobin in the blood can cause ischemic anoxic injury, in particularly in the globus pallidus. The lesions will show low signal in the T1, high signal in the T2, and the flare, and the lesions will show diffusion restriction if the condition is acute, and the treatment is 100% oxygen to eliminate the carboxyhemoglobin from the blood. Then what is the differential diagnosis of basal ganglia abnormality? There is a very long list of diagnostic possibilities, including infection like toxoplasmosis and Behçet disease, viral encephalitis, ischemic conditions like artery perfusion, basilar tip occlusion, hypoxic ischemic encephalopathy, hypoglycemia, internal cerebral vein thrombosis, neurodegenerative diseases, autoimmune encephalitis, FAR syndrome, neurofibromatosis, Leigh's disease, osmotic demyelination, and Wilson disease. Toxins like alcohol in cases of vernix encephalopathy, carbon monoxide neurotoxicity, cyanide and methanol toxicity. And tumors like the case I have presented, diffuse astrocytoma, diffuse midline glioma, and the primary CNS lymphoma. This patient is 20 years old, presented by acute onset of conscious disturbances. And this is MRI T1, T2, flare diffusion, and ADC. Yes, and the answer is right. These are infarctions in the brainstem. Always think of the lesions that cause diffusion restriction to be infection or ischemic acute insult. Sometimes the lymphoma can cause diffusion restriction. In this case, you got bilateral midbrain or hypontine infarctions, and the underlying cause is occlusion of the basilar artery. And I said previously that the occlusion of the basilar artery is incompatible with life, but this is not right, since occlusion of the basilar artery can result in bilateral brainstem infarctions, and it can be sometimes managed by interventional radiology. This is a female patient, 61 years old, presented by headache. This is CT, T1, and T2 weighted images. Okay, then this is fat-containing lesion. It can be a lipoma and can be a dermoid cyst at the cerebellopontine angle. Then this was a lipoma at the cerebellopontine angle, and this lesion is also, to my mind, seen in the clinical practice. Although it is a benign lesion and anyone can think that this can be easily removed, but actually the surgical intervention of such a lesion carries very high risk of vascular and nerve injuries. Then we, myself, have seen many cases with lipoma at the cerebellopontine angle. It will show high signal in the T1 and T2 with signal loss in the fat suppressed images. This lipoma at the cerebellopontine angle accounts for 10% of intracranial lipomas. And one of the um, uh, conditions which hinder the surgery is that the facial and vestibulocochlear nerves crossing through or coursing through the lesion. This lipoma may cause sensory neural hearing loss. Then the differential diagnosis may include hemorrhagic acoustic neuroma, which will not show fat suppression in fat suppressed images. Thrombosed aneurysm will also will not be suppressed in the fat suppression. Ruptured intracranial dermoid cyst you got fat signal in the subarachnoid spaces. And this is one of the criteria of the dermoid tends to cause leak and the CSF spaces. Of course, if you look to this case with multiple lesions in the cerebellum and in the cerebral hemispheres, then the diagnosis is easy, and this you should consider the possibility of metastasis. The answer is right, and be sure that these are not, for example, tuberculomas, because these lesions are homogeneously enhanced, and also multiple lesions would be thought to be metastatic deposits until proved otherwise, even if you do not know that the patient had a primary malignancy. But if you know that the patient had a primary malignancy, then the first possibility should be metastatic deposits. This patient and the FLAIR image and the contrast enhanced image, he is known to has fungoid mycosis. And this disease can be also seen that fungoid mycosis or mycosis fungoids, both can fit. If you know what is a fungoid mycosis, then you can easily diagnose the case. But if you do not know, this fungoid mycosis is lymphoma of the skin. Lymphoma, if the patient is known to have lymphoma of the skin, then you know that these periventricular lesions will represent a lymphoma as well. And sometimes the lymphoma may show very weak or even very faint contrast enhancement. And then the next case is a series of brain study, including the FLAIR images, the T1 post contrast. This is FLAIR and T1, and this is FLAIR and T1 with contrast. Yes, the answer is right. This is meningitis. You got high signal in the CSF spaces, meaning that this is no more CSF, and you got enhancement of the meninges and the leptomeninges. This is meningitis, and of course, the frequent cause of meningitis in our country is related to TB, but many other causes can be included. Since you see only meningitis and you do not see any other suggestive criteria. This patient is a female patient, 47 years old. She has positional headache, nausea, double vision, and memory impairment. This is the T2 weighted image, and this is T1 post contrast, and this is also T1 post contrast. And this is just to compare the normal appearance by the pathologic appearance. Intracranial what? Craniopharyngioma? No. But I think that he and hemangiopericytoma, no. And intracranial hypotension, this is the right answer. Intracranial hypotension has many imaging findings like diffuse meningeal thickening of the dura, distension of the dural sinuses, prominent appearance of the pituitary gland. These are the criteria of intracranial hypotension. Enhancement of the brachiomeninges, meaning the dura, not the leptomeninges. downward displacement of the brain through the foramen magnum, subdural fluid collections as you see here. The enhancement of the pachymeninges may be diagnosed as meningitis sometimes, or may be confused by lymphoma, for example, or granulomatous disease. Distension of the venous sinuses and reactive hyperemia of the pituitary gland. The brain sagging is a specific finding and is identified by effacement of the suprasellar cistern. The suprasellar cistern is almost obliterated, bowing of the optic chiasm over the pituitary fossa seen in the coronal images, flattening of the bones. The bones is usually rounded from its anterior aspect, it now straight against the clivus, downward displacement of the cerebellar tonsils through the foramen magnum. And this is the prominence of the pituitary gland, and this is the flattening of the anterior aspect of the bones compared to the normal appearance. This is these findings support the diagnosis of spontaneous intracranial hypotension with distension of the venous sinuses and the enhancement of the dura, as I have said. Thank you very much.